I will discuss postoperative radiotherapy and radiorhythmic trials that we are conducting among the rhythmic network. So it's very clear that the management of patients with thymic malignancies rely on multidisciplinary assessment, and we obviously recommend multidisciplinary tumor board to be organized for the management of patients, including the decision making for postoperative radiotherapy. So I mean that the decision for any strategy is based on a discussion between surgeons, medical oncologists, radiation oncologists, and it is not one specialist who will decide for a given strategy. What we know with postoperative radiotherapy is that here are the data from ITMIC, the ITMIC retrospective database, that in Thymoma, stage 2 and stage 3, according to Masaoka, we have a benefit in favor of postoperative radiotherapy. It's clearly a benefit that is sustained over time. And if we look at these retrospective data, it's quite convincing that patients should receive postoperative radiotherapy. Still, these are retrospective data, so we don't really know why patients receive postoperative radiotherapy or not. And in this setting, it's quite difficult to really know what is the magnitude of benefit for which subgroups of patients. For example, a patient with a large 7 centimeter tumor, even if completely resected, historically, many of us were actually treating those patients with postoperative radiotherapy because of the size of the tumor. So, and in patients with smaller tumor, we expect radiotherapy may not have been delivered. So, I mean that based on retrospective data, it may be quite difficult to understand the drivers of the decision making. So then, hard to interpret the data. Here is another meta-analysis with postoperative radiotherapy, a fair number of patients, nearly 5,000, looking at stage 2 and stage 3 individually. And looking at this data, we see a consistent benefit in stage 2 and stage 3 thymomas after complete resection. Still, if we look at the magnitude of benefit, it may be actually quite limited if we go deeper into the data. For stage 1 thymoma, after complete resection, it has become very clear around 10 years ago that postoperative radiotherapy was not adding any kind of benefit. We now have consistent data for those patients with encapsulated tumors, stage 1 per Masaoka Koga. It's not the stage 1 that we have right now based on TNM, because stage 1 per TNM also encompasses tumors that are not encapsulated or even with some involvement of mediastinal structures. So here it's stage 1 per Masaoka, encapsulated tumors. There is no benefit of postoperative radiotherapy. And then comes the stage 2 and stage 3. Here are stage 2 data. Again, the analysis from the US database. We have some benefit of port in stage 3B per Masaoka, so more than 3 millimeter extent outside of the capsule. So there seems to be a benefit, but you can see that the magnitude of benefit seems to be actually quite limited, even more limited in stage 1 and 2A in this analysis. Same thing for the Chinese report. And also, we can see here that we have a limited number of events and many patients who are censored, so we do not have a clear follow-up for many of these patients. Maybe histology is something also to integrate in assessing the benefit of postoperative radiotherapy. And we know that type A and AB thymomas are actually more indolent tumors with less proliferation. Still based again on the ITMIG analysis, uh, we do not see that much impact of the histology after complete resection, especially in stage 2 tumors. Maybe in stage 3, we see obviously more events in each arm, and we have obviously an earlier observation with the outcomes of the patients. In those curves, in those survival curves or DFS curve, we actually look at any recurrences and not only the recurrences in the radiation field. And we know that in thymoma, many of the recurrences are not located in the mediastinum where we apply radiation. Many of the patients, about 70% of recurrences, occur in the pleura, and this is one of the papers. We have a similar report from Gustave Roussy that was published more recently. So that's very clear that when we assess DFS in patients who are receiving or not receiving postoperative radiotherapy, we need clearly to distinguish in-field versus out of the field recurrences. The story is quite different in thymic carcinoma, where we have consistently a report of a benefit of receiving adjuvant treatment, adjuvant radiotherapy. It's clearly more aggressive disease, and we have a consistent benefit in all the retrospective studies that have been conducted. These are the ESMO clinical practice guidelines, so quite complex, the 2015 algorithm. For sure, it will be simplified in the upcoming version that will be published this year. In this algorithm, we distinguished clearly thymic carcinoma from thymoma. In thymic carcinoma, we recommended postoperative radiotherapy even in stage 1 tumor, which may be discussed, but at least we have this consistent benefit. In thymomas, after complete resection, we stratified the recommendation not only based on stage 1, no postoperative radiotherapy, stage 2A, again, per Masaoka-Koga in type B3 thymomas, and in stage 1B from B2 and B3 thymomas. So clearly, we tried to adapt. The objective was to have a kind of uniform way to treat the patients, to be able also to assess at the end in a more effective manner the retrospective data. At the end, we still have the question of what is the magnitude of benefit and how we can move forward with more information for postoperative radiotherapy. Very important to see that in all those data sets, it's based on Masaoka-Koga, and that's very clear that we need also to generate data based on TNM, because with the TNM that is collapsing in the stage 1 category, many of the some of the stage 3 Masaoka-Koga and all the stage 2s, well, there is some complexity here in assessing the subgroup of patients, especially when we see that in stage 1 and stage 2A per Masaoka, we do not see that much benefit of postoperative radiotherapy, when in stage 2B and 3, there is clearly a question regarding the efficacy of postoperative radiotherapy. So to me, there is also now a challenge to generate data with the outcomes of patients, even retrospective data with postoperative radiotherapy or not, based on the TNM staging system. What we also developed part of the RADIORYTHMIC network is a RADIORYTHMIC trial. So prospective randomized trial in thymic tumors, so thymomas, any histology, stage 2B and 3 per Masaoka, which is a cluster of patients where we believe that there is a potential benefit. It also includes patients who may have received preoperative chemotherapy. We are randomizing 276 patients to receive postoperative radiotherapy or no postoperative radiotherapy with a follow-up that is in line with the ESMO and RITMIC guidelines. That's obviously a challenging trial because it's always hard to recruit patients in an adjuvant study, whatever it is, even in lung cancer. I have to say that we have a quite good adhesion of the patients with this concept of randomization for postoperative radiotherapy or no postoperative radiotherapy. The study is now opened in 14 centers. We have now recruited almost 70 patients, so that's not too bad. We have more centers coming also outside France, hopefully, and the study is obviously continuing. We are obviously collecting all the CT scan and all the data. We are also collecting staging according to the TNM to be able also to look at subgroups of patients. Waiting for that and hopefully enrolling patients, as many patients as possible in RADIORYTHMIC. We clearly need to discuss the management of patients, obviously in a national multidisciplinary tumor board such as the RHYTHMIC one, but we have also opportunities with the Euracon European network, with ITMIG. There are many tumor boards that are open to discuss the management of those patients. This is obviously a collaborative effort. So I would like to thank obviously people from my team, but also all the people who are working part of RHYTHMIC, especially Benjamin, especially Angela, who is my co-PI on RADIORYTHMIC, and Thierry, because obviously the pathologists are key in this trial. We have a pathology review before enrolling the patients to make sure of the histology and stage. It was clearly helpful to build this trial, to organize this rapid pathological review, also to organize and to discuss the way we deliver radiotherapy, and this will be presented by Angela. Thank you.